This is a rough guide to what the ventilatory settings are when we consider extubation. It depends on the mode of ventilation you are using, and as we know, we are moving away from sedating babies. I'll have a short talk on sedation quickly soon, but in terms of synchronized modes, obviously assist control, SAMV, PSV modes. In SAMV, we aim for extubation when the PIP reaches around 16 to 18, and in a baby with the birth weight less than 1000 grams in assist control, we aim for a map of 7 centimeters, and in a bigger baby we aim for a map of 8 to 9 centimeters. FiO2 ideally should be below 0.3. So the rate, the stress on rate doesn't stay as we used to when I was training, so we don't worry much about what rate as long as the baby's effort is okay. In volume targeted ventilation, we wean the tidal volume, and if weaning the tidal volume alone is difficult, you can for a brief time switch them to SAMV with pressure support. In high frequency ventilation, in a baby below 1000 grams birth weight, the map of less than 7 and FiO2 of less than 0.3, and in a baby more than 1000 grams, a map of more than or equal to 9 centimeters and FiO2 below 0.3 can be criteria. High frequency jet ventilation is not much used outside the US, but the criteria are mentioned here in case your unit uses that. So what are the factors to consider when we review the baby readiness? So first point is to assess the readiness for extubation on a regular basis. So in a baby on antibiotics, we have the routine practice in antibiotic stewardship to assess whether the baby needs antibiotics on a daily basis and stop it at the earliest. In case of central line access, we have this checklist to check every day whether we need it. It's part of the care bundle. Similarly, in an intubated baby, always assess the readiness to extubate, wean the baby, and extubate at the earliest possible, unless you make a calculated decision that this is a 24-weeker and I want to keep the baby intubated for the first week or two. Of course, some units keep them longer in the tiniest babies, especially the 22, 23 weekers. Once we reach the ventilatory settings as described earlier, which indicate readiness to extubate, we review the blood gases, mainly the pH and PCO2. Capillary blood gas should be good enough as most of these babies may not have arterial lines. Then we assess the blood pressure and need for inotropic support. If they are on inotropic support, it's always better to allow them to stabilize, wean them off the inotropic support, and then reassess the readiness to extubation, because you don't want to stress these babies, and ventilation as a supportive measure is quite useful in these babies as well, even though it's for a short time. Look for presence of risk factors like sepsis, NEC, hemodynamically significant PDA. So I'll be discussing these separately in a supportive care as well. But in terms of sepsis, obviously if the baby is responding well to the treatment, you can extubate after 24 to 48 hours of a diagnosis if baby is stable. NEC is a different scenario because giving non-invasive ventilation is going to get extra gas load and distend the tummy more, which may not be ideal. So again, this is one of the cases where supportive ventilation till the baby is improving is an option, gentle ventilation. So we also need to make sure that the measures to improve the extubation success, like a loading dose of caffeine, should be in the system. Consider an additional top-up dose if the loading dose was given earlier, and you can consider in the tiniest babies a higher dose, maintenance dose, when you are extubating these babies if you have started them